Welcome to Bear in Mind, the Brown Psychiatry Podcast. Clear, current content about mental health.
Here's the second part of our conversation with Dr. Meghan Riddle about Alzheimer's. So you mentioned about some diagnostic tests that are available through research studies, and also we know that there are many drugs being investigated right now. So how does someone get into a clinical trial for Alzheimer's?
So in Rhode Island is tiny but mighty, particularly related to Alzheimer's disease research. So there's the Memory and Aging program here at Butler, which we have multiple active studies going on right now looking at Alzheimer's disease and related dementias. Individuals can go on clinicaltrials.gov, and you can actually search by what you're looking for to see what clinical trials are enrolling. Lifespan also has a memory specialty clinic that has clinical trials and clinical care. There's also a place called Rhode Island Mood and Memory that does different research trials related to Alzheimer's disease. Butler itself has something called a registry, which you can go online and sign up for. It asks some basic demographic questions about yourself, and basically makes it where if there's a study that you might qualify for or be interested, states that you're willing to kind of receive information about that.
Great. And any national platform that people can access to find trials that are going on besides clinicaltrials.gov? Is there any through the Alzheimer's Association or any additional information?
So Alzheimer's Association, you can basically search by zip code, and it tells you, what's going on there. It can connect you with support groups, connect you with, other clinical chapters. Clinicaltrials.gov, most people, have their studies registered there, and that way you can see what's actively enrolling. We've talked some about clinical trials in terms of investigational medication, but there are also trials that are observational. And so for a lot of people, putting themselves out there to receive an investigational medicine is scary and just not as comfortable, particularly people who are new to research. We're part of longitudinal studies that are observational over time that involve data sharing here in Rhode Island. And so there can be things in terms of basic neuroimaging. So we mentioned earlier some of these specialized brain scans. People can get access to those scans as well as the results of those scans by participating in these research studies, and they are international. And so the idea is that as we collect information over time, that's going to help shape how we intervene with this disease and when we intervene with this disease. It's also worth noting that there are studies for people that are unimpaired cognitively, meaning that they haven't noticed any changes so far, but they either have a family history or they're concerned and can enter into research in that way. We're part of a trial called the AHEAD trial that looks at one of these anti-amyloid medications called lecanemab for people that are cognitively normal, meaning they don't have any changes cognitively, but based on access to these specialized scans, we know that they're at risk because they're accumulating amyloid or they have a genetic risk factor, that ApoE4 gene. And so the idea is if we give you this drug to remove amyloid before you have any symptoms, could we prevent you from ever getting Alzheimer's disease? And this is the change in the field now is, I mentioned being kind of on the brink of something because we are finally getting some results after years that by impacting certain targets, we can separate people and help preserve their quality of life and function, help delay the progression. I would assume, just like other chronic diseases, that it's going to be more than anti-amyloid or anti-tau. It's going to take a multi-pronged approach. Kind of the next phase of investigation is, well, how do we target, precision medicine? How do we identify who is best suited for what types of treatment?
Go back and specifically talk about any local resources for families and patients in Rhode Island. Can you think of anything that is potentially you'd recommend for people to check out?
So, I think a place to start is honestly with your primary care providers. Oftentimes there's case management built in. We have a social worker in our clinic that can help connect individuals to some of these other services that I mentioned through the Office of Healthy Aging, as well as the Alzheimer's Association. There's a wonderful program in Rhode Island called CareLink that has received grant funding and that we work with very closely, and that they send occupational therapists or speech language pathologists actually to the home. And because it's a grant fund, it's free to the individuals. They're able to do assessments. There's a type of approach called skills to care. So they're working with the care provider in the home, teaching them ways, how do you change communication? How do you change the environment within your home? It can be something as simple as removing rugs that are tripping hazards, adding safety kind of supports like a shower bar, making the home more accessible, to, basically changing your language, how you communicate, how to respond to someone when they're asking the same question over and over again. What's a helpful response? What tends to be more distressing? Really some basic education to help with the level of safety, but also distress in the home for the caregiver as well as the person living with dementia.
So going back to prevention, could you describe some more specific tips that you have around prevention? You mentioned about lifestyle changes, but also I'm wondering about sleep apnea and anything else about substance abuse or cognitive stimulation, anything else that you could recommend to our listeners?
So, I think for going back to why early diagnosis is important, this is really why, is that it gives people an opportunity to intervene. I think we all know that we should, it's not a novel phenomenon that we should eat healthy and not smoke, but actually seeing that it moves some of these markers, particularly around chronic health conditions. So having a close control over your blood pressure, your cholesterol, your blood sugar, ways to impact that being, physical activity, not having a sedentary lifestyle. There's research looking at midlife obesity as a significant risk factor for development of Alzheimer's disease. I think in terms of a social stimulation and emotional connection, we really saw the impact on older adults with COVID, and not even just older adults, all of us, how having, losing access to our social support, becoming more isolated and withdrawn, what that did to our overall health and well-being, and how important these social connections are. There's senior centers in Rhode Island that are an incredible resource, as well as adult health centers or adult daycares where people can go and get supervised stimulation and relationship building. There's a lot of hesitancy around things like assisted living, but actually what we found is that when people transition to assisted living, because they have peers and friends and activities and are engaged, people's mental health improves quite a bit. Right. And while it's certainly, I don't want to minimize the difficulty of leaving your home and an environment you're familiar with, there are some benefits that are untapped. And so a nice kind of toe in the water to that is to attend some day programming to get people used to participating in these skills. Certainly lifelong education, so challenging your mind. We know that higher education is also protective. It builds up cognitive resilience. You don't have to learn to speak another language. It can be something as simple as learning a new hobby. But staying engaged and challenge yourself is incredibly important. There's also disparities when they look at prevalence research related to gender. So women, 1 in 5 women are impacted by Alzheimer's disease, roughly 1 in 10 men. There are different suspicions around that. Is that a survival bias? Is that the women are living longer and it's actually age that's more important? Is it hormonal? Is it opportunity? So we know that, people that have access to occupation earlier, which certainly that has changed for women over the last few decades. It's more protective if they're engaged in an occupation, and again, around challenge and cognitive stimulation. There's also a race disparity, and so Black older adults are 2 times as more likely to develop Alzheimer's disease. Hispanic older adults are 1.5 times as likely to develop Alzheimer's disease compared to white older adults. And again, I think it goes back to social disparities and, exposure to stress, appropriate access to diet and health, appropriate access to health care and management of these chronic health conditions. Again, the importance of how these risk factors are modifiable and making sure that everyone has equal access and emphasis on this care to make a difference for their lives.
So one of our goals with this podcast is to provide information, access to care, as we understand how challenging this is. So I'm wondering if you could talk a little bit more about what are some barriers to accessing care and how to overcome them.
So, it's not just barriers to access to care in Alzheimer's disease. I think it's barriers to access to care in health, whether that is, again, going back to some social disparities, whether it's, we think about research, the atrocities that were performed in a research environment. People are very hesitant and skeptical, and for good reason. I think there's a level of trust that needs to be built and established. I'm thinking about the idea of actually going into communities and developing relationships over time being the most impactful. I think, what we've talked about in the Memory and Aging program is, you can't say, come to us, and we have all these tools and trials that we can give to you, but actually going into showing that you care about the citizens of your state, building relationships, offering things and services, making sure that challenges to access of care like transportation, hours of operation, not everyone can get there 9 to 5. Going back to transportation challenges of, you can't tell somebody they can't drive anymore, but also expect them to be at your appointment at 3 p.m. There are a lot of areas that, I think even with COVID, just kind of the explosion of virtual care and how we can use that mobile access for lab draw, that the CareLink program that I mentioned, just what a difference it makes to send someone to the home and see how someone is living. That makes a practical difference in an everyday life. And so, yes, access to medications is one thing, access to trial is another thing, but from a practical safety daily standpoint, making sure that we're doing all that we can and thinking outside the box of how to bring care to other people, how to reach other people, I think is a very high priority.
This is making me think back to some of these newer treatments that we were talking about and, how much monitoring they'll require and how much care and quality care that they'll require to administer them safely. And so I'm wondering, how do you kind of address concerns about safety with these newer treatments and kind of balance that with access?
Yeah, so it's a new frontier and is a significant issue. So last summer when aducanumab first got FDA fast-tracked, we were the first program clinically to prescribe aducanumab and felt comfortable doing so because we had been part of the clinical trials for so long and are fortunate to be part of a research enterprise and a care enterprise within Rhode Island where people do have access to regularly scheduled imaging, care. There's a stroke service that if something were to go wrong, people could get, evaluated. And, having that be here made it a bit easier to make that transition. But then you think about disparity in, okay, well, this is an urban environment, an academic environment, people that have specialized training and exposure. I'm from Kentucky. I would not feel comfortable, frankly, in certain parts of Kentucky for people to be on these treatments, knowing how far it would be to travel to get care or even, have access to different types of imaging or specialty support. And I think part of rolling out access to these medications is that has to be a primary concern. We haven't talked much in depth, but one of the primary side effects and safety concerns related to these anti-amyloid drugs are these fluid shifts. And so you can have brain swelling. It's also called edema related to these medications. You can also have small brain bleeds. And so you need quality and consistent care that's reliable with people that are familiar. Again, these are new treatments. Not everybody has had I wasn't exposed to these treatments when I was in training. So this is a new frontier, even for people who are on the front lines, and they've been controversial. So I think there's a significant conversation around balancing risk versus benefit. And yes, it's an incredible achievement to actually move the needle on cognition and function using these medications, but is that enough to warrant putting certain individuals at risk? And how do you identify who's appropriate to receive these medications and minimize that risk for a chance of benefit? And there's also just the ethical overlay of people with Alzheimer's disease know that it's progressive, know that it's terminal, and you're dealing with a population that can become desperate, and you want to make sure that you balance your first do no harm, making sure that there's equitable access, but not taking advantage of somebody's willingness to take more risk for the potential of a small benefit. And so we have a lot of conversations as a team. These decisions are not made in silos, but for a lot of our patients, we've known them for a long time, and what we ran into with kind of the advent of these medications is, what's the cutoff? Like, what are the requirements for someone to safely receive these medicines earlier on in the illness? And how difficult it is to tell someone that, unfortunately, their disease is too advanced and we don't know enough about the risk or the potential benefit. Those are hard conversations to have. On top of just the financial inequity around, if they're not covered by CMS, are we going to have drugs that are only available to people who can afford them?
Right.
And that is another area of significant concern and ethical responsibility, and one that will continue to come up. So this summer is, and just over the next few weeks, is going to be another wave of information coming through. So lecanemab applied for traditional FDA approval. So before now, there's not been a medication that received traditional FDA approval that CMS does not cover. And so thinking about what are the qualifications, who are they going to identify as those appropriate to receive treatment? Are they going to cover it? Are they going to change the requirements for individuals to receive that medicine? And then for individual providers and healthcare systems, are people going to prescribe it? Do people feel comfortable in their own ability to safely monitor and care for individuals? And these are questions that we're all going to face over the next few months, both from an exciting standpoint, and that we actually have an opportunity to provide some of this treatment, but also you want to balance that with doing it the appropriate way.
So you just mentioned about the controversial aspects that came up when aducanumab was approved. How do you address that in your office? How do you discuss benefits with your patients?
So for aducanumab specifically, our office was part of several of the clinical trials leading up to its approval. So we have had years of experience. I say we because it is a large team of individuals that participate in these trials and in our clinic. So we were comfortable with the use of that medication, and we're familiar with the data. Participants and individuals in Rhode Island help contribute to that data. And a lot of the conversation were ongoing conversations. So people that were familiar either with the study or had been with us, for years. We really just answered the question directly with the information that we have, with the caveat that it's continuing to evolve. And so the controversy for aducanumab was that it was FDA fast-tracked based on kind of this essential kind of reasonable likelihood to benefit a group of people that didn't have other options. But the research wasn't so obvious. So there was a study that really showed no separation or no improvement with individuals on aducanumab in terms of their cognitive function. And then another study showed that it was helpful. And so, we were very frank about that, is that, these are the risks that we know of receiving the medication, the amyloid-related imaging abnormalities being of most concern. A way to mitigate that risk and have a more informed discussion about that risk is through the ApoE genotyping. So we know because of research that if someone is an ApoE4 carrier, they're more likely to develop this side effect with aducanumab and other anti-amyloid drugs like it. And so actually part of our clinical management, again, because we're fortunate enough to be have access to research, we're able to clinically swab and everyone receive their genotype so they can make the most informed decision for themselves based on their risk. And so that was something that we required, is that everyone know their genotype and have access to their genotype. The reason that's important is ApoE genotyping is not clinically available, is not commercially available. So I couldn't order that test for insurance to cover for everyone. We had access to it. And so part of kind of the ongoing conversation of how to roll this out safely was working with the FDA and saying, okay, well, actually feel that this should be required. This is something that should be considered if we're going to prescribe this, because we know that it matters and it plays a part into people being able to balance the risk of these significant symptoms to help make their decision. And so that was part of our conversation, as well as the fact that we just didn't know. And so Center for Medicaid and Medicare Services required that if people wanted to receive aducanumab, that it be through a clinical trial to continue to gather information, because it was not definitive, with the idea of being that as we learn more over time, we can help add to the information on, does the potential risk of developing these side effects outweigh or not the potential benefit, and what is that benefit? I think with lecanemab, its results coming out that showing the separation in cognition and function, that actually people on lecanemab separated. They did better. They preserved what they had compared to those who were not receiving it. It was not controversial, and the data supported that. But what the questions that kind of arose from that are, well, what does that mean? Because in a research study, we're using a secondary measure. So we're using a test that, as the kind of the endpoint, basically to distill what someone's daily life and functioning is. So what does it mean if somebody's 30% better on this test than those who are not, from a practical standpoint? Is that 6 more months of their current quality of life? How do we measure that? How do we explain that to a family? And again, it's unclear. These are kind of moving targets, ongoing, evolving conversations. And, my general rule of thumb, the way that I practice, is to have those conversations out loud and be very honest about what we don't know, what we're trying to learn more about, and that sometimes there isn't a clear answer. Most of the time, it's kind of in the vague gray, but that these are decisions that are made together, and as more information comes to light, that can continue to inform what we do, and we can always change. We can always change course and pivot based on what we learn and what we know.
Are there any books about Alzheimer's that you would recommend and that you find to be helpful for patients and caregivers?
That's a good question. There's a book called The 36-Hour Day that most people have heard about and talked about, and for good reason. I do this with trainees as well. Is if I'm going to recommend something to read, I want it to be understandable, accessible, and practical. Otherwise, people aren't going to finish it. You're not going to glean anything from it. And that is something that I think is very easy to, depending on where you are on the journey, there's something that you can glean from that. And it can grow with you on the journey. So, and I feel that way about the Alzheimer's Association website as well. So while it's not kind of a book or a written resource, there's so much information, again, that is short, digestible, and you can access it when you're ready and when it's applicable, and it also helps you plan for the future.
Yeah, thank you so much for that information about the amyloid-lowering treatments, and I think that there's been a lot in the news about those, but what other kind of studies are going on now that you think people should be aware of? Are there other drugs coming out, other things that is really exciting?
Yeah. Absolutely, and to your point, a lot of emphasis has been put on these, and I think it's just the excitement in the field, the fact that so much energy, funding, frankly, intelligence has been poured into this, people coming at this from multiple points of view. But yes, anti-amyloid is one piece of a very large puzzle. We've talked about research around some of the modifiable risk factors. There are several lifestyle prevention studies that are taking place, again, looking at how do we intervene early. In terms of other clinical trials, there are trials currently enrolling looking at anti-tau medications as well. So tau is the other protein that's involved in Alzheimer's disease. Here at Brown, there's a study called Line AD that we partner with Dr. Sedavi, looking at repurposing a medication that's actually already FDA approved for HIV, called Emtreva, to see, can we use a medicine that's already readily available and repurpose it to target neuroinflammation. And so brain inflammation, we know, is, again, a significant contributor to decline. And if we kind of make an impact and a run at it, is there another way that we can address and help people's quality of life?
Excellent.
Thank you so much, Dr. Riddle. This was extremely helpful. It was great talking to you. Now, a take-home message to bear in mind.
When it comes to Alzheimer's disease, it's important to remember how crucial early detection and diagnosis are. By recognizing the signs and symptoms early on, we can take action and provide the necessary support and treatment. As we discussed, early intervention can help slow the progression of the disease and improve the quality of life for patients and caregivers. We also want to stress the importance of research and clinical trials in finding new treatments for Alzheimer's. Finally, if you're a caregiver, it's also essential to take care of yourself and ask for help. We still have much to learn about this disease, but there is hope for the future.
And lastly, as Alzheimer's can often be associated with depression, anxiety, other mental health problems, if you or someone you know is having suicidal thoughts, please contact the Suicide and Crisis Lifeline. Call or text 988 or access 988lifeline.org. The Lifeline is a 24-hour toll-free phone line for people in suicidal crisis or who are just emotionally overwhelmed. You can also go to the nearest emergency room and ask for help. The Alzheimer's Association also has a 24/7 hotline for patients and families needing support. The number for them is 800-272-3900. And for more information on clinical trials, you can contact the Butler Hospital Memory and Aging Program Outreach Team at 401-455-6402.
Thank you for listening to our podcast. For more information related content, please check out our Instagram, Facebook, and YouTube channels. Bear in mind the Brown Psychiatry Podcast. Thank you.